In this video, I'm going to briefly talk about the interpretation of lung ultrasound as it pertains to nephrology practice. Lung ultrasound is one of the easiest scans to perform and a very useful tool in assessing the volume status of a patient when interpreted in conjunction with physical examination and findings from other ultrasound exams such as IVC and the heart. As described in the volume status lecture, we typically evaluate 4 lung zones on each side, which we get using parasternal line, anterior axillary line, and posterior axillary line, and a horizontal line just below the nipple. So we get 4 examination sites on each side, and areas 1 and 2 denote upper anterior and lower anterior chest, whereas 3 and 4 denote upper lateral and basal lateral chest respectively. Examination typically begins in the mid-clavicular line at the second or third intercostal space with a probe marker pointing towards patient's head. And the probe is aligned as perpendicular to the chest wall as possible to get the best picture. We can use abdominal, that is the curvilinear probe, which I like to use for the most part, or you can also use the phased array or the cardiac probe. If you don't need deeper penetration and you are just evaluating the pleura to look if pleura is sliding or not, a high frequency vascular probe can be used. I mean, remember, the high frequency probe does not penetrate deep, while if you use a lower frequency probe, you get deeper penetration and you can assess the deeper parts of the lung. Assessment of an air-filled organ such as lung is a limitation of ultrasound in general because air scatters the ultrasound beam and doesn't allow proper visualization of the underlying structures. However, this limitation paradoxically turns into a diagnostic advantage when you're doing lung ultrasound because all we are interpreting here are artifacts such as A lines and B lines. First, we will talk about the normal appearance of the lung, that is A line pattern. So what are we looking at here is lung ultrasound, and these are ribs here, and they cast a shadow beneath them because they don't allow the passage of ultrasound waves. So the space between 2 rib shadows is called one rib interspace, and we evaluate each lung in multiple rib interspaces. And this bright line here is the pleural line. So pleural line is slightly inferior to the main ribs or at the beginning of the rib shadow. Sometimes you can see like brighter lines above this line, especially in obese patients, and that does not represent pleural lines. The pleural line should be here below these ribs. And now this pleural line, if you carefully observe, it oscillates or has some shimmering that moves with the lung, that is called pleural sliding and represents moving of parietal and visceral layers. And when there is no pneumothorax, that means when there is fluid in between these pleural layers, like normally they have, you will see this pleural sliding. And these bright lines here, which are parallel to the pleural line and equidistantly located from the pleural line, they are the A lines. And if you see A lines, that means it's a normal pattern of the lung and indicates that lung is filled with air. How are these A lines formed? So essentially A lines are reverberation artifacts. So when the ultrasound probe transmits waves and listens back to the echoes, here this is the pleural line, and pleural line is adjacent to air, so air is a strong reflector of the sound waves. So some of the waves go back to the probe and back to the machine for analysis, and that's represented as the real pleural line. And some of the waves bounce back and forth between the pleural line and the probe interface and do not enter the probe for interpretation. So these echoes here take twice as much time as this echo. So the machine thinks it is lying deeper compared to the pleural line. So similarly, like if this echo here takes 3 times as much longer compared to the first echo, so the machine thinks this echo is coming from the deeper place compared to this one. And similarly, as the reverberations repeat, you have multiple parallel lines. It's just that the intensity of these lines keep decreasing as we go deeper. So this is how A lines are formed. Now we will discuss some of the commonly encountered abnormalities. The most common abnormality we are looking for in nephrology practice while evaluating the volume status are B lines. B lines are the vertical lines like this here, and they arise from the pleural line and go till the end of the screen. And these represent a thickened interstitium or interstitial edema in the lung. They are very helpful for the nephrologist in assessment of volume status, especially in ICU patients and end-stage renal disease patients on dialysis. The precise mechanism causing them is not clear, but they are believed to be a form of reverberation artifact called the ring down artifact. This occurs when there is a specific type of air fluid interspace is formed. That means when there is a fluid in the interstitial septa of the lung that is surrounded by the alveolar air in the form of bubbles, and it forms like a tetrahedron, like the fluid stuck in between the tetrahedron formed by the gas bubbles. And when the ultrasound beam reaches these air bubbles, it is capable of exciting the liquid that is trapped in between the bubbles, and each vibration of the liquid causes a continuous source of sound that is transmitted back to the transducer, and it's represented as a line. When this happens in a quick succession, this vibration, you have multiple horizontal lines that are closely spaced, and when you look at it, it appears like a vertical line. So each of these vertical line is a B line. So essentially B lines are a form of ring down artifact. So what are the characteristics of B lines? So B lines are long vertical hyperechoic lines, which is in contrast to the normal A lines, which are horizontal lines. And B lines arise from the pleural line. And if B lines are arising from somewhere outside the pleura, they are not B lines. I mean, if some vertical line is coming from the subcutaneous tissue, it's not a B line. And if some vertical line is starting below the pleura, that's probably not a B line. And B lines move with pleural sliding. As the lung moves, these lines move. They are not stationary. And they continue to the end of the image. They don't stop here. There are some artifacts which start at the pleural line and just run a short distance and stop. They are not real B lines. And also remember that B lines usually erase A lines. If you are seeing B line pattern in the lung, it's very unlikely that you will see normal A lines. B lines used to be called comet tails and lung rockets because of their vertical appearance, but this terminology is no longer used. And if we say comet tails now, most likely we are talking about other artifacts that just start at the pleural line and don't go till the end of the screen, which are relatively common. Are B lines always abnormal? No. It's normal to see occasional B lines, that is less than 3 per 1 rib interspace, especially in the lung bases. And this is most commonly seen in elderly subjects. And what does an abnormal B line pattern mean? It essentially means 3 or more B lines per rib interspace, like this here. So these are ribs, this is pleura. So this patient has 4 lines here. This is an example of a B line pattern. And now what is diffuse B line pattern, also known as interstitial syndrome? It is 2 or more positive regions per side, and it likely indicates pulmonary edema. So this is one B line pattern. So if you have 2 or more positive regions like this per side, remember you are evaluating at least 4 zones on each slide. So if you have at least 2 zones positive on each side, that represents diffuse B line pattern and most likely indicates pulmonary edema. And if you have like B line pattern in like 3 zones here and none of the zones here, that's not considered diffuse B line pattern. And what are confluent B lines? It essentially means that there are numerous B lines in close proximity, and essentially it makes it difficult for you to count the number of B lines. When you see these confluent B lines, it's most likely indicative of significant pulmonary edema. This is how pulmonary edema looks like. So we are looking at multiple rib interspaces here. So all these are rib shadows. That means this is one rib interspace, this is one rib interspace, and this is another. So you see like multiple B lines starting at the pleural line here and going to the end of the screen, and they're moving with lung sliding. So they are definitely B lines, and there are numerous B lines, making it difficult for us to count individually. So these are confluent B lines in multiple rib interspaces, most likely representing pulmonary edema. And they look similar to this, like the sun rays nicely coming from cloudy sky. That's how these B lines are compared to. And are B lines seen only in pulmonary edema or congestion? In other words, if you see B lines in the lung, does it always mean the patient is volume overloaded? Again, the answer is no. B lines can be seen in pneumonia, they can be seen in atelectatic lung or the collapsed lung, or it can be seen with lung contusion in a trauma patient, or they can also be associated with pulmonary infarction or a pulmonary mass, or if the patient has focal pleural disease or fibrosis. But typically most of these causes are unilateral and localized to the area of pathology. And you likely see associated consolidated lung if it's pneumonia, or you might see effusion if you are dealing with collapse of the lung, or you have history of trauma if you are dealing with contusion, and you might actually see a mass with maybe associated malignant pleural effusion if you're dealing with malignancy. And they can also be diffuse and bilateral, especially if the patient has bilateral interstitial lung disease. It essentially depends upon the clinical context rather than just looking at the B-line pattern and starting diuretics. This is an example of lung contusion, where this is the pleural line and you see numerous B lines in this rib interspace. This patient had trauma and contusion resulting from that. And some other things you might want to know about B lines are the number of B lines correlate with the amount of lung water. And in dialysis patients, reduction in B line number following dialysis correlates with volume of ultrafiltration and weight reduction. It may actually guide therapy. And as soon as you dialyze the patient, you can count, and almost immediately the number of B lines will come down. And in these patients, normal lung auscultation findings do not exclude hypervolemia. So you can auscultate your dialysis patient and say that the auscultation is normal, but still on ultrasound you might find B lines indicating subclinical hypervolemia. So in those circumstances, quantifying the B lungs and looking at them again after dialysis would really assist in challenging the dry weight. And also B line burden correlates with symptomatic dyspnea assessed by the NYHA class. So more water in the lung, more number of B lines. So are these B lines? So look at the first picture. These are actually common artifacts seen in more than 80% of the population. These are called Z lines. And these bundle-shaped lines arise from the pleural line, but do not erase A lines and do not move in synchrony with the respiratory movements. And they do not go till the end of the screen. So these are not B lines. And what about these things? So this is actually an example of E lines. And they represent subcutaneous emphysema. So remember, air is white on ultrasound, right? So here is the pleural line, and here are all these broken white things with some shadowing. If you carefully observe, you see some random shadowing coming from these white lines. Obviously, you don't have stones there in the near the pleural space, right? So and these will be moving. If you are looking at a video, these will be moving a little bit, and these represent air in the subcutaneous tissues or subcutaneous emphysema. So both these patterns, if you see Z line pattern and E line pattern, don't confuse them with B lines. Pleural sliding. As nephrologists, the main purpose of doing lung ultrasound is to see if there are B lines and if the patient is hypervolemic. But because you are scanning these critically ill patients in the ICU, it's also important for you to know some of the incidental findings that you may encounter, which might be potentially hazardous if you don't act right away. So you need to know what pleural sliding is, what it represents, and what if it's not there. So the presence of pleural sliding is one of the most important findings in normal aerated lung. The sonographer should visualize the hyperechoic pleural line in between two ribs, this pleural line between the two ribs. These are rib shadows, these are ribs, that's moving or shimmering back and forth. That is representative of lung sliding. And it corresponds to the to and fro movement of the visceral pleura on the parietal pleura that occurs with respiration. It is a dynamic sign and can be identified on ultrasound as a horizontal movement along the pleural line. Sometimes you'll not be sure if you're seeing lung sliding or not. And in those circumstances, you can use the M mode or the motion mode to confirm pleural sliding. And as you know, when you turn on the M mode, you get a line like this. And what it represents is it gives you a tracing here, which represents movement of the part beneath this line over a period of time. So it only tells you about whatever is behind this line, and it plots over a period of time. So it gives you the movement or the motion. That's why it's called M mode. And so when you turn on the M mode and bring this M mode cursor to the pleura, what you'll find is the pleural line and the immobile superficial structures appear smooth and linear like this, like the smooth and appearance here. And the area deep to the pleural line, so the area deep to this bright line here, takes a granular or sandy appearance. And sometimes this is called the sandy beach appearance. See the top linear layers, they are compared to C, and this granular appearing thing is compared to sandy beach. So when you see the sandy beach pattern, that means it's a good thing. And when the lung is not expanding due to absence of ventilation, or if the patient has pneumothorax, or if the patient had undergone pleurodesis, the appearance of stationary structures fills the M mode. Now this M mode tracing, when the lung is not sliding, it looks like a barcode. So it's called the barcode sign or the stratosphere sign. See here in this moving picture, you see that lung is moving with respiration, but there is no sliding, there is no shimmering of this line. It's just like one bright line, and there is no oscillation. So on M mode, it looks like a barcode. So if you see something like this, probably the patient has pneumothorax. And what is lung point? So lung point is the junction between sliding lung and the abnormal lung where there is no sliding. That means if the patient has pneumothorax, you are likely to find the lung point also. This is the abnormal lung where there is no sliding, and this is the normal lung. The junction between these is called the lung point. See here, the shimmering is very obvious, like something shiny thing is going on, but here there is nothing moving on. I mean, overall the pleura is moving with respiration, but not one layer above the other. And here you can see both, if you turn on the motion mode, you can see both the sandy beach pattern and the barcode pattern. And this junction is called the lung point. So you have a beach and the barcode. And another common abnormality you would notice is pleural effusion on the lung ultrasound. So pleural effusion is seen as a hypoechoic region above the diaphragm. Fluid is black on ultrasound, right? And in terms of orientation, this is the liver here, and your probe marker or the screen indicator is on this side, which means we said you hold the probe marker towards the patient's head. So this side becomes superior or towards the head, and this side is towards the feet. That means this bright structure above the liver would be diaphragm, and whatever is above it is the lung when the patient is lying down. So this black thing here above the liver is pleural effusion. And a small effusion will only be detected posteriorly in the supine subject. So this is anterior and this is posterior, because closer to the probe is anterior because you are scanning from front of the patient. And a larger pleural effusion will be more anterior because it starts expanding and coming towards the front of the patient. Now, what is the spine sign? When no pleural fluid is present, there's a sharp cutoff of the vertebral bodies at the level of diaphragm. See, these are vertebral bodies. These bright things here with shadows, these are vertebral bodies. And if you don't have effusion here, if the lung is filled with air, you don't see these vertebral bodies here. But now that there is effusion allows the ultrasound waves to pass through it. So there is ultrasound wave transmission till the ribs, till the vertebrae. So you see these vertebral bodies and those shadows above the diaphragm, and you see the whole spine here in continuity, and that's called the spine sign, or sometimes thoracic spine sign. So if you are seeing the thoracic spine on ultrasound here, most likely you're looking at effusion, or the lung has some pneumonia or some fluid in the lung that's allowing the ultrasound waves to pass through it. And this is the example of a complex pleural effusion. And this is the liver here, this is the diaphragm, and this is the pleural effusion. And you can see here fibrin stranding and some hyperechoic structures inside the pleural fluid representing complex pleural effusion. And this part here is most likely consolidated lung, which almost looks like liver. Okay, now another common pathology that you would encounter is pneumonia. So consolidated lung looks like liver on ultrasound, and it has a tissue density unlike the normal air-filled lung, but it is superior to the diaphragm. So this is the liver here, and this is the diaphragm. And again, you are seeing something like liver here, that is the lung that became like liver. That represents consolidated lung. And these white structures here, they represent air in the smaller airways of the lung, and they are air bronchograms. Like the air bronchograms you see on X-rays, they appear like this on the ultrasound because air is white on ultrasound. And sometimes there is a mirror artifact above the diaphragm, which is just a mirror refraction of the liver, which essentially looks same as the liver, but this is not mirror artifact because you are seeing air bronchograms. If it's a reflection of the liver, you wouldn't see these air bronchograms. And these are called dynamic air bronchograms. So dynamic air bronchograms are air bronchograms that are moving with respiration. See these things, these white things nicely moving in the smaller airways of the lung with each breath. So essentially this is a consolidated lung here. And even with consolidation, you can see these vertebrae, thoracic vertebrae, because lung is not totally air-filled. And here is another example of the consolidated lung. And this is the diaphragm here, and this is the liver or spleen. And these are air bronchograms nicely moving with respiration. So these moving air bronchograms are called dynamic air bronchograms, and sometimes they are compared to wiggly worms. And now what is shred sign? So essentially shred sign is seen in alveolar consolidation, and it represents the shaggy irregular border between consolidated lung and the normal aerated lung. Normal aerated lung, you can't really see the tissue texture, and consolidated lung, you see it appears as it appears like a liver, and that's called the shred sign. And the last pattern that you want to know, how a atelectatic lung appears like. Atelectasis has a pattern similar to lung consolidation. That means it has a tissue density unlike the air-filled lung, and echogenicity is similar to that of liver or spleen. You can also see air bronchograms like you see in pneumonia, but the major difference is that these are static air bronchograms. That means with respiration they don't typically move. You just see these white things here, you note these white things, but they are not moving like the worms. You compare them to the dynamic air bronchograms, they are nicely moving with respiration. But if it's atelectasis, it's very likely that they don't move with respiration. One thing to remember is that static air bronchograms, that is stationary air bronchograms, can be seen both in atelectasis and pneumonia. But if you are seeing dynamic air bronchograms, it most likely represents pneumonia and not atelectasis. And also the other difference is that if the patient has pneumonia, it's most likely associated with some degree of pleural effusion, but the amount of pleural effusion would be smaller. And if the amount of pleural effusion is big, that it is collapsing the lung, most likely it's atelectasis. Also, if you are seeing fibrin stranding or multiple echoes in the pleural fluid suggestive of pus, so your consolidated lung is most likely a result of some infectious process rather than collapse from the pleural effusion. And sometimes this atelectatic lung, the way it moves in the surrounding pleural fluid, it feels as if a jellyfish is swimming in the water. So that's also called jellyfish sign, or sometimes it's also called the lung flapping. And I think we covered most of the common pathologies that we see on the lung ultrasound. And thank you. And if you have any comments or if you want to share any nice images, you can share them on Twitter to this Twitter handle NephroP, which is dedicated for point-of-care ultrasonography in nephrology. Thank you.